Hello, my name is Paula Anderson with Paula Anderson Coaching and Consulting, and today we're going to have a lesson on surgery coding guidelines. So this is going to be a brief introduction with surgery coding. So I want to make sure that you understand some of the basic principles that are needed in order to code surgeries. Now, we're not going to go very in-depth into actually coding specific subsections. We're just going to go over some of the basic principles. So let's get started. So your PowerPoint presentation that you have within this lesson is going to give you the information that we're going to go over. So the first thing that I want to talk about is the CPT surgical package definition. And so this lists what is included in the CPT surgical package. And of course, this is based on the AMA. But you have different payers that may have their own surgical package, such as CMS. But we'll talk about some of the things that are included. So evaluation management services subsequent to the decision for surgery on the day before or the day of surgery, including history and physical. So this indicates that if a patient is having a surgical procedure done, that the physician is going to evaluate them before they proceed with the surgery. So that's not going to be a separately billable service. Local infiltration, metatarsal, metacarpal, digital block, and topical anesthesia. So these anesthesia services are a part of the surgical care. The only anesthesia services that are going to be billed separately would be the regional, the general, and also the epidural. And those will be billed by the anesthesiologist. Immediate post-operative care, including dictating operative notes, talking with family. So those are going to be services that are going to be included in the patient's follow-up. Writing orders, evaluating the patient in the post-anesthesia recovery area, and then typical post-operative follow-up care. So we'll talk a little bit more about some of these items. Now, there are two different types of procedures. You have major versus minor procedures. So a major procedure would be a procedure such as a breast mastectomy. So normally a major procedure has a 90-day global period. And if you're coming in for an office visit and the physician decides that you need to have an emergency surgery and it's considered to be a major procedure, then you want to pin modifier 57 to the office visit, and that lets the payer know that that was the decision for the surgery. So that's the only time when the E&M service is going to be separately billable. Your minor procedures would be considered as 0 to 10 days. And so an example of that would be a colonoscopy. Colonoscopy is a diagnostic procedure where you're viewing the colon to see if there are any problems. If this colonoscopy is done at the same time as an office visit, you want to make sure that the documentation supports a separate examination apart from the colonoscopy procedure, because all procedure codes do have an E&M component within them. Now, the surgery consists of three parts. You have pre-operative, intraoperative, post-operative. So normally you have one physician that's going to do all three components, but there are times when one part may be done by another physician. So it could be that the post-operative care is done by a different physician. Payment for all components. So normally if it's not any type of complications, one provider is going to receive reimbursement for all services, but there are times when there are complications. So if the patient has to go back to the operating room, then there is a modifier that's going to be required, and that's going to be modifier 78 for an infection. Uncomplicated follow-up care, again, there is a CPT code that you can report in your billing record to indicate that the patient did come back for their routine follow-up care, and that's going to be CPT code 99024. Procedure. So when a patient comes in, of course, they're going to be seen for diagnostic purposes based on the symptoms or the signs they come in with. But then if there are some problems that need to be corrected, then that diagnostic procedure is going to convert to a therapeutic procedure if both procedures are done at the same time. So an example is if a patient has a colonoscopy and then the surgeon decides that he's going to do he finds some polyps or he finds a tumor, and he's going to remove those at the time of that colonoscopy. Well, then the diagnostic procedure turns into a therapeutic procedure. So you're only going to bill for the therapeutic procedure because it is the larger procedure. And that brings us to the concept called separate procedure. So in your CPT manual in your surgery guideline pages, you have a definition of the word separate procedure. And separate procedure means the opposite of what we actually define the word separate. So it means that it's a larger component of a larger procedure. So for example, with the colonoscopy, that is the separate procedure. But if they do something a little bit more extensive, more that requires more work, then that's going to be the larger procedure. So the diagnostic procedure becomes inclusive of the therapeutic procedure. So will not want to unbundle those. So you would not be able to bill both of those. And so the correct coding initiative edits, those are the guidelines that we have to follow in order to determine whether or not we should be unbundling or if we should be billing only one code for a particular service. Now, modifier 59 can be utilized when there are instances when you can put a 59 on their procedure code, but you want to make sure that you follow the CCI edit guidelines to determine whether or not you can actually do that before you try to bill those codes. Now, there are surgical modifiers that we're going to talk about, just kind of brief introduction to those. We do have a separate module on modifiers. So we'll talk about modifier 50, which means bilateral, modifier 52, which is reduced services, modifier 53, which is discontinued procedure, modifiers 54, 55, and 56. So 54 is the surgical only, 55 is going to be the post-op, and 56 is going to be the pre-op. Also modifier 58, which is stage or planned procedure. Modifier 76, repeat procedure by the same physician. Modifier 78, return to the operating room. And then modifier 79, unrelated procedure by the same physician. And then modifier 80, surgical assistance. So these are just a few of the surgical modifiers. Our module on modifiers actually explains how to apply each one of these modifiers with examples. Now, coding an operative report. An operative report is the medical dictation that the surgeon actually writes up through some type of transcribing system. And he indicates these things in the report. So he indicates the preoperative diagnosis, the postoperative diagnosis, anesthesia, whether it's general, regional, or epidural, the surgeon, the procedure name, and then the procedure details. So this indicates what information is going to be contained on the operative report. So this is my recommendation for coding operative reports. So the first thing that you want to do is you want to read it so that you can get an understanding of what's being done. Then you want to analyze it so that you can actually figure out what procedures are going to be coded. And then the third thing you want to do is you want to read it so that you can code it. So you want to, during the analyzing process, you want to make sure that you underline keywords, procedures that you see within the operative report. Look up any medical terms that you're not familiar with. And also make sure that you pick out any modifiers that would have to be assigned for that particular case. So I hope that you enjoyed watching this lesson on surgical coding guidelines. And again, we have specific modules to help you to learn more about specific subsections within the CPT manual. So thank you so much, and stay tuned for more lessons from Paula Anderson Coaching and Consulting. Thank you. All right, good. Go back and redo all those.